Good afternoon, and thank you very much for the very nice introduction. And I would like to express my thanks to the Hellenic Society for the study of risk factors of cardiometabolic diseases, and particularly for its president, Professor Kyriakis. Really, cardiometabolic risk factors are key issue, and today I'm going to discuss non-alcoholic fatty liver disease as one component of this cluster. These are my disclosures. And you know, the world where we are living today is different than it was some 10 years ago, because there is definitely maladaptive lifestyle as shown over here, and that leads to both, or is linked to both, overnutrition and physical inactivity. And there are different issues in the society which are causing this. But the end result over there is then the positive caloric imbalance, which leads to visceral abdominal obesity, and that means also imbalanced insulin action, and the result is the ectopic lipid accumulation and atherosmetabolic syndrome. Non-alcoholic fatty liver disease is really a serious challenge for the health in the face of obesity and type 2 diabetes epidemics that you very well recognize. And non-alcoholic fatty liver disease is defined by the amount of liver fat exceeding 5% per liver weight by magnetic resonance imaging, and that's a golden standard for the measurement of liver fat content. It's very common, but its prevalence varies quite a lot in different ethnic groups. And very recent clinical data really indicates that this clinical and economic burden of non-alcoholic fatty liver disease is enormous. And there was just a paper published in Hepatology where they estimated the cost to be $130 billion in US. So the prevalence rises rapidly in obesity as well as in type 2 diabetes, where it has been estimated to be present in 60-70% of the patients. So this is really a major health concern. As said, prevalence increases in parallel with rising prevalence of obesity and type 2 diabetes. As I already said, there is a lot of variation in different population, and some of that is shown over here. You see the numbers for US and Europe, almost 25%, but particularly then Middle East, Asia, and also South America, the numbers are very high. And of course, over here, you are very close to the Middle East epidemics, and you will face consequences of that. So those are really the really big problem places for non-alcoholic fatty liver diseases. Very recently, last year, three European societies, that means European Association for the Study of Liver Disease, European Association for the Study of Diabetes, and European Association for the Study of Obesity, published in Diabetology an issue which was focused really on this problem, and that also includes the guidelines, the current guidelines produced together by these three societies. And you know, if you want to get more information concerning the logistic for the diagnosis and so on, part of that is also published in the same journal where my colleague, Professor Ykijärvinen, had this mini review on the diagnosis of non-alcoholic fatty liver disease, very nice algorithm how you should work in your clinical practice. So where does the liver fat come from? That is, of course, a key issue over here. And one of the point over here is that we need to understand the liver lipid metabolism to understand how the fat accumulates in the hepatocytes. And over there are two important processes. That is the input of the fat in the liver and then the output of the fat in the liver. considering the input of fat in the liver, the most important source, of course, lipolysis in adipose tissue and the free fatty acid coming from the circulating fatty acid pool. On top of that, there's also fat coming from the diet and a spillover of the lipid particles, which leads to input of triglycerides. But it's also very important that other diet components, particularly glucose and other sugars, can directly contribute to the liver fat by increasing de novo lipogenesis, and I will share some data on this part. Then, considering the pathways which take the fat out from the liver, there are only two ways, in fact. Either the fat is packed in these violeal particles which are secreted then into the circulation, or then the lipids are directed to mitochondria and then they are oxidized over there. And there's much less data concerning the lipid oxidation than the other pathways. But the key point is that this hepatic steatosis results from the imbalance between these two processes, that is increase of FFA and TG input and decrease in free fatty acid and TG output. So it's an imbalance between input and output. What is neglected part concerning the production of lipids in the liver is really the de novo lipogenesis. And as already pointed in the previous slides, there's two important factors regulating de novo lipogenesis, and those are glucose and also insulin, because they regulate the two important transcription factors, carbohydrate response element binding protein and sterol ester binding protein, and also LXR. So all these together activate all the enzymes for the de novo lipogenesis, and this is a key why the sugar-sweetened beverages is so bad for the health and particularly for the liver, because in diabetes, of course, we have this milieu, because you have increase of glucose and increase of insulin that then stimulate the pathways that promote de novo lipogenesis. And it's highlighted over here that, in fact, increased de novo lipogenesis seems to be a very distinct feature in non-alcoholic fatty liver diseases, and it really increases the hepatic lipid burden. And this has been neglected because the methods to measure de novo lipogenesis has been pretty poor. But nowadays you can use stable isotope and heavy water and directly measure the incorporation of that into de novo lipogenesis. So the factors which really are important over here are, first of all, the excess substrate supplies, that is glucose, fructose, then the transcriptional regulation, and also the excess uric acid generation is coming particularly from the fructose metabolism. But there are also other players in the game, and there's more and more information coming out that your microbiome may influence also this de novo lipogenesis by different pathways, where at least some of the inflammatory cytokines are playing a role. And it's not only de novo lipogenesis which is the consequence, but there's also a consequence of increasing beta oxidation, because that leads to ROS production, and then if the fats are directed to the wrong pathway, there will be lipotoxicity in the liver. And all this then results when there's increased secretion of VLDL in this atherosclerotic profile with hypertriglyceridemia and all the other well-known components. I will just share with you some very new data from an international group that I had the pleasure to lead, because this study was run by funding from the European EASD research sources. And we were feeding fructose 75 grams per day over 12 weeks to healthy obese subjects who definitely have the metabolic syndrome. And the co-workers over here were Nabels, Professor Riccardi, and also Professor Deprez from Quebec City, as well as the team in Gothenburg. And we did do the imaging, and we followed up the liver fat responses, as well as several other cardiometabolic risk factors. But I just show you the changes in liver fat content over here, and these are changes. And to our big surprise, the response was highly variable, and even at the same level of weight change as shown over here. We also looked at the changes of subcutaneous and central fat as shown over there, and there the variation was less, but again, there's a lot of variation. And in fact, this fructose was served on top of ad lipidem diet, so the diet was hypercaloric at the end. But despite all that, some people really did lose weight, and those are now the blue ones over here. Then there was a big group of people who remained weight stable, and then there was those people who really increased weight. And there was an expected correlation between the liver fat change, which overall increased, and the weight change. But, of course, this raised the question, what really is going on? What are the factors which are causing this huge variation? In this study, we looked at different metabolic factors as shown over here, and the group 1 represent now those who lost weight, and group 3 those who gained weight, and there are the parameters before and after intervention. And there's very little changes over here in this group who lost weight, and in fact those people also had loss of liver fat. But then if you look at the other group, first of all, there was increase of all those parameters linked to the body fat, as well as also HOMA as a surrogate measure of insulin resistance. And then, interestingly, because we used the heavy water, we measured the de novo lipogenesis. There was also highly significant increase in de novo lipogenesis in this group. In fact, the actual increase was more than 30% as shown over there. And also, interestingly, there was increase of ApoC3, which has become out as a very important regulator of the triglyceride lipoproteins. So it means that these very important cardiometabolic risk factors are truly increased by fructose feeding, but again, there's a lot of individual variation, and this is linked also to the weight gain. So the next question, of course, is that is this non-alcoholic fatty liver disease always associated with insulin resistance and increased of risk of type 2 diabetes? Because insulin resistance has been one component of this cluster. So first, I would like to point out that if you look at the mechanism involved in the pathogenesis, so there are the increased visceral fat, then that is associated with insulin resistance and, of course, increased free fatty acid fluxes, and this has the consequence of both glucose metabolism and lipid metabolism, and the end result is hepatic steatosis, and if inflammation is included, it develops into steatohepatitis. And already, as pointed out, the role of intestinal dysbiosis is to be extremely important, particularly for the development of NASH. So what is known about the insulin resistance and the different components? We had the opportunity to study about 75 obese men who had abdominal obesity, and we categorized them according to the measured liver fat in 3 groups, those with low, moderate, or high TG, hepatic fat, as shown over here. And, if we look at all other parameters between this group, it's quite clear that in those who had high hepatic fat, they had also all other components of cardiometabolic risk, the big waist, as shown over there. They had the lipid abnormalities, and also the HOMA index was increased as expected, and also there was some increase in free fatty acids. So it's truly a cluster. Also, this has been shown in the population-based study. If you call Framingham Heart Study cohort population-based, and they looked at the different rates for these cardiometabolic risk factors, which has been discussed also in this conference in details. And again, insulin resistance came out as a very strong trait over there. So came also the lipid abnormalities, hypertension, and then the combination or definition of the metabolic syndrome. So that's not a big news. Then recently there was this nice publication from US where they looked at the association of non-alcoholic fatty liver disease, and they used two indexes for the measurement of insulin resistance, the adipose tissue insulin resistance index, and then also the suppression of free fatty acids. And they had two groups, people who were not diabetic and divided either non-obese or obese, and then those who were diabetics and had either non-obese or obese, as shown over here. And in both groups, non-alcoholic fatty liver disease was clearly increased if you had obesity. So it looks out that also these were highly insulin resistant, as shown by the indexes, that patients with non-alcoholic fatty liver disease have more severe systemic and adipose tissue insulin resistance than subjects were out, as clearly shown by these blue columns over here, and the reduction considering the suppression of free fatty acids. Recently, however, it has been discussed that what is the importance of these two well-established genetic risk alleles for the liver fat development and also for the insulin resistance in the liver. And the two genes are indicated over here, TM6SF2, and then BNPLA3, which has been on the table for much longer time than the other one. How they really increase liver fat is not completely established yet, but it is. They are both modifying the liver lipid metabolism. There are in vitro studies indicating some mechanistic pathways considering, for example, the excretion of fat out from the liver, but it's still not really finalized in humans. So Hannele published just recently this review article because they have looked at the components of cardiometabolic risk and insulin resistance according to the genotypes, and to the big surprise, in fact, those who were carriers of the risk alleles of these two genes, over there the liver fat was definitely increased, but there was not a real clear reduction in insulin sensitivity. The NASH risk was increased, risk of cirrhosis was increased, and then of course that means increased risk of hepatic carcinoma. And to big surprise, these genetic risk allele carriers did not have abnormalities in lipids or coagulation factors. So they included that there was no increased risk of thrombosis and no risk of this really pro-atherogenic markers over here. And this suggests that the genetic variants are not associated with insulin resistance, in contrast to this obese metabolic non-alcoholic fatty liver disease. So I think that we can conclude over here that there's very close correlation between non-alcoholic fatty liver disease, where the genetic risk factors are predictors for the hepatic fat content. On the other hand, considering the association with the insulin resistance and type 2 diabetes risk, that seems to be more linked to this obese cardiometabolic phenotype than to the genetic factors. And of course, there's very close relationship between these two factors as highlighted over here. So genetic factors are strongly associated with the hepatic fat content but have no predisposing effect on type 2 diabetes. So my next question really is very critical to the topic of my presentation, that is, why is non-alcoholic fatty liver disease dangerous for the blood vessels and a CVD risk factor? And first of all, I would like to point out that fatty liver really is the worst kind of fat depot because it secretes from the liver a cluster of different cardiovascular risk factors. It's not only glucose and lipids. There are also increase of factors which promote procoagulation and pro-fibrinogenic factors, as well as factors associated with hypertension, inflammation, and so on. And then there are two interesting, more novel factors, FGF21 and phenytoin A, which seems to be also very seminal in the liver lipid metabolism. And in fact, we have here, considering the lipids, these three components: increase of triglycerides, lipoproteins, the remnants, small dense LDL and HDL reduction. And these three together really increase the cardiovascular risk. And considering that all these factors are metabolically closely interrelated, so it's very difficult to dissect out which is the criminal or are they partners in the crime. Recently, there was nice data coming up again from the US population-based cohort that these specific risk factors of the atherogenic dyslipidemia, ApoB and ApoA1 ratio is elevated in people where cardiovascular, now I lost again this one, cardiovascular non-alcoholic fatty liver disease in both non-obese and obese group, and also LDL particle size is reduced in both. There's also already pretty old data which shows that there is also elevation of remnant lipoproteins in type 2 diabetes and fatty liver. And this is based on the Japanese studies where they did measure the remnant-like lipoprotein cholesterol as shown over there, and triglycerides. And they had the subjects were no fatty liver and no diabetes, and those who had diabetes and then either or no fatty liver. And it's quite clear that those who had fatty liver had highly significantly higher concentration of both remnant-like triglyceride and remnant-like cholesterol as compared to those who did not have. And why is this important? It is important because atherogenic triglyceride lipoproteins, the size matters. The size matters. Can these particles really penetrate the arterial wall? And over there, the critical borders are shown over there, and you have the flow of these particles either coming from the liver or from the gut and then the remnants. And in fact, it's so that if the particles are smaller than 700 angstroms, then they can go through the arterial wall, also these remnants, which are coming from both chylomicrons and VLDL. And it's particularly this area which represents the remnants. And the remnants can be calculated using the normal measurement, that means triglycerides and HDL. And atherogenic remnants comprise all cholesterol is in these remnants of chylomicrons, VLDL, and IDL species. And this is important because of their size. Most remnant particles, really the big one, cannot cross endothelium, but as efficiently as smaller LDL particles, but the smaller one can. And each remnant particles contains approximately 40 times more cholesterol compared with LDL. So even a more smaller number is bad. And the accumulation of these remnants in postprandial state really promotes a retention of these remnant particles in the arterial wall. And that is bad for the vascular wall. So non-alcoholic fatty liver disease associates also with a new concept which is fatty heart, and that means cardiac steatosis, and this leads to impaired cardiac function. And what does cardiac steatosis comprise is fat accumulation in 3 different spaces: epicardial fat, pericardial fat, and then cardiomyocyte fat, and that can be also measured by the spectroscopy. And the cardiac steatosis is really associated with both visceral and hepatic fat contents, insulin resistance, and inflammation. And this means that lipotoxicity in the heart is a hazard, as it results in energetic inefficiency reflected in cardiac dysfunction, leading eventually to the heart failure. And this was discussed in the previous workshop over here, if I understood correctly the titles. So we have looked at this group of people who had abdominal obesity men, and as said, categorized them in 3 groups who had either low, moderate, or high hepatic fat. And we also measured these different other ectopic fat depots by using either MRI or spectroscopy. And the most important ones are over here: the myocardial triglyceride content, epicardial and pericardial fat. And as shown, there was increased fat in all these 3 components if you had high hepatic fat. So all 3 cardiac fat depots accumulates with increasing amounts of liver fat and visceral adiposity. And we also used very sophisticated measurement provided by the cardiac MRI imaging to look at different measures or parameters of the left diastolic dysfunction. And over here, 2 parameters are shown: the peak filling rate and the peak filling rate across the left ventricular end-diastolic volume. And please note, again, we have the same groups according to liver fat, but the left ventricular mass was the same in all these 3 groups. But there was quite clear-cut reduction in these parameters of the left ventricular function. So those who belong to the highest group of intramyocardial fat, as shown here, also had higher liver fat and the parameters of diastolic dysfunction. And this was shown also in the cardiac study, which includes is a big cohort, 2,700 patients, and they looked at the patient were and without non-alcoholic fatty liver disease, measured abnormal left ventricular relaxation and the high LV filling pressure, and both of those parameters were increased. Those with a high were more common in those with a high liver fat, that means non-alcoholic fatty liver disease. So the cardiac complications associated with this non-alcoholic fatty liver disease are several. It's not only the cardiac dysfunction and cardiac hypertrophy which leads to heart failure, but there are emerging number of papers coming up quite rapidly, reporting, for example, association with different arrhythmias as well as different valve diseases, particularly aortic valve sclerosis, and then, of course, there's a lot of papers association now with coronary heart disease. So non-alcoholic fatty liver disease is an independent risk factor for the clinical burden of cardiovascular disease, and really associate with a plethora of cardiovascular risk factors, including both traditional and non-traditional factors. But these traditional risk factors cannot explain the connection, so there is also some direct effect, and it probably is linked to this lipotoxicity in the heart. And of course, non-alcoholic non-alcoholic fatty liver disease associated with increased prevalence and incidence of cardiovascular disease. The key message to take home is that the majority of deaths among non-alcoholic fatty liver disease patients are attributable to cardiovascular disease. These disorders share the common pathogenic mechanism, and there are multiple mediators, but as I said, the underlying mechanism are not quite clear yet. Importantly, I think that we can say that fatty liver leads to a broken heart, and that is a second message to take home. So finally, before closing, I just would like to come to the point which has been discussed and what's the topic of this particular conference, and that is, of course, the management and prevention of cardiometabolic risk factors, and that's also the goal for the international share on cardiometabolic risk, the ECGR. And that includes all these factors. And over here, the ultimate goal is to prevent also non-alcoholic fatty liver disease. And there's so far only 3 ways to influence that. That means eat well, drink well, and move. So it means that the lifestyle changes are critical because there's no drugs available so far approved for diagnosis of non-alcoholic fatty liver disease. For NASH, there are several under evaluation and in different phases. So I think that truly lifestyle modification is of critical importance in the battle against non-alcoholic fatty liver disease. And I would like to close by inviting you to participate in this international meeting next May, which will be in Quebec City, and that's organized by ICCR, and there will be a lot of interesting new presentation on these issues presented over there. So thank you very much.